I'm Dr. Tony Hanneman with MedStudy, and I'd like to bring you today a short, or at least the shortest, simplest way I could come up with for evaluating acid-base disorders. I've even given it a name. It's called the Tony Hanneman Common Sense Approach to Evaluating Acid-Base Disorders, or, more shortly, THMCASATRIABITID. Well, the really cool thing about this is that you just write down your lab results and a couple of calculations in a very particular order. And it's by doing this, three things occur. One, it becomes easy to remember. Two, the order itself drives the analysis. And three, it makes understanding the analysis process much easier. So let's get started. First, write down the following in this exact same order each and every time. pH, PCO2, expected PCO2, bicarb, and anion gap. Each and every time, write it down in this order. Now we'll look at pH, PCO2, and bicarb. pH gives you your overall acid-base status. You'll either be alkalemic, neutral, or acidemic. PCO2 and bicarb give you both the respiratory and the metabolic components that add up to this particular pH. And these are the only two components you need to look at to get the pH. If you look at the Henderson-Hasselbalch equation, you'll see only these two contribute to the pH. And you might wonder, well, why is that so? And the reason why is because we have a bicarbonate buffer system in our bodies. If you look at this bicarbonate buffer equation, you can see carbon dioxide on the right, carbonic acid in the middle, and bicarbonate on the left. And this set of equations are all in equilibrium. The carbonic acid itself is a very weak acid, so it tends to hold on to the hydrogen ion. And anytime an acid is added to the body, most of the H ions get sucked up by the bicarbonate buffer system. This weak acid only allows a small range in pH normally, 7.35 to 7.45. Okay, look up at expected PCO2 and anion gap. So the expected PCO2 helps you further figure out what's going on with the PCO2. The anion gap helps you further define what's going on with the bicarb. Expected PCO2 is 15 plus bicarb, and it's always at. It doesn't matter if the bicarb's low, neutral, or high. Expected PCO2 is 15 plus the bicarb. And this is kind of tying in both sides of the bicarbonate buffer equation that we saw earlier. How does this work? Well, say you have a bicarb of 20 and you have expected PCO2 of 35, 15 plus 20. And say your PCO2 is 45. Expected PCO2, which is the normal response to the bicarb. And even though it's 35, it wouldn't be considered a metabolic acidosis. It's just simply a response to the bicarb. Your actual PCO2 is 45. So you're retaining more CO2 than expected. Because of the difference between the PCO2 and the expected PCO2, you have a respiratory acidosis. Similarly, if you have a PCO2 of, say, 20 and your expected PCO2 is 35, then you have a respiratory alkalosis. You're hyperventilating and blowing off CO2. Okay, let's look at anion gap. Similar to how expected PCO2 further informs you about the PCO2, the anion gap further informs you about the bicarb, and it lets you know if there's multiple metabolic components contributing to the metabolic status. Let's take a moment and look at the 4 steps of acid-base analysis. Now, although we kind of thought of it conceptually like pH and then the respiratory and metabolic components of pH, for the actual analysis we go through 4 general steps. First step is looking at the pH, see if you're acidemic, alkalemic, or neutral. We look at the PCO2 and the expected PCO2. to understand the respiratory component. For step 3, we look at bicarb alone, and that gives us our net metabolic status. There's two kind of stages to anion gap, 4A and 4B we'll call it. 4A is where you just do the anion gap, sodium minus the sum of chloride plus bicarb. If it's above the 18 to 20 range, you have a high anion gap metabolic acidosis. If it's normal, you have a normal anion gap metabolic acidosis. Simple as that. High anion gap metabolic acidosis is further looked into. Look at 4B there. You check and you make sure that the increase in anion gap is about equal to the decrease in bicarb. What if the anion gap increase were 10 and the decrease in bicarb were 20? That means you have a much deeper metabolic acidosis than simply due to whatever is causing the high anion gap. So you'll have an additional NAGMA, normal anion gap metabolic acidosis on top of that. Conversely, what if you have a high anion gap and your bicarb is, say, 22? It's in the normal range. What does that mean? So your bicarb is not as low as you would be expecting. So there must be a metabolic alkalosis going on. And that's all there is to it. So that there is the 4-step method. Now, there are two options that you need to do sometimes. We'll call it option 1 and option 2. The first one is if the patient is obtunded or intoxicated and you don't know why, you do an osmolar gap. You're familiar with this. High osmolar gap metabolic acidosis means that it's probably a toxic alcohol, especially if the osmolar gap is greater than 25. That's methanol, ethylene glycol, or propylene glycol. Methanol, ethylene glycol, or propylene glycol. If you have a high anion gap but a normal metabolic status, think isopropyl alcohol. And you can see the other causes of it here. Option number 2, you always do a urine anion gap if you have a NAGMA. Why is that? If you have a NAGMA, that means you have a normal anion gap metabolic acidosis. The most common causes are either a bicarbonate loss in the stool, usually from diarrhea, or hydrogen ion retention, usually due to an RTA. Urine anion gap is negative if it's a gut loss, and I think negative gut loss. It's normally 0. And if it's 0 positive, you think RTA. Okay, let's do some questions. After I read the questions, stop the recording, try and do it yourself, and then go on to the explanation. Okay, question number 1. We have a 36-year-old man who's brought to the ED following a shooting. Arrives with a blood pressure 60 palpable, actively bleeding exit wound. Get right to the acid base. pH 7.22. We're writing this down in the same order every time. PCO2 25. Expected PCO2, leave blank. Bicarb 10. Anion gap. Now we go back and calculate. Expected PCO2 is 25. Anion gap is 107 plus 10, 117, 139 minus 117. That's 22. Starting from the left and moving right, we do an evaluation. Primary metabolic disorder is acidemia. PCO2 is simply reacting. It's the same as expected. So it's simply reacting to the bicarb. We can ignore it. Bicarb is 10. There's a definite metabolic acidosis. Anion gap is 22. There's a definite HAGMA. And remember, anytime you have a HAGMA, you definitely have, by definition, a metabolic acidosis. Let's go to the 4B area and compare the increase in anion gap with the decrease in bicarb. Increase in anion gap is 22 minus the normal is 6. So it's 16. Anion gap has increased 16 above normal. Bicarb is 10. It's 15 less than normal. So 15, 16. They're about the same. We have a simple HAGMA going on. Question number 2. We have a 43-year-old alcoholic. He's admitted to telemetry, has chest pain. Morning after admission, he appears inebriated and is acting delirious. No tremors. Last drink was in the car before admission 24 hours ago. He's receiving only aspirin, metoprolol, lovastatin, and nitropaste. We have his blood pressure is normal, heart rate 100, temperature normal, respiratory rate 10 to 12. Sounds a little low. Pulse oximetry 92%, somnolent, laughing, and soon becomes attunded. Okay, pH 7.33, PCO2 45, bicarb 23. Now expected PCO2 is 23 plus 15 is 38. And anion gap is 9. Go ahead and calculate that. Okay, going left to right. 733, we have primary disorder is an acidemia. And PCO2 is higher than expected PCO2. We're retaining carbon dioxide. There, he's hypoventilating. He has a respiratory acidosis. Bicarb is normal. Anion gap is normal. This patient has a straightforward, simple respiratory acidosis. Now, this patient is obtunded, and we don't know why. So he would definitely do an osmolar gap. An osmolar gap is serum osmolality measured minus calculated. In this case, calculated is 2 times 139, which is 278, plus about 5, 288 from 305. So we do have an increased osmolar gap. Because this patient's metabolic status is normal, we would have to exclude isopropyl alcohol poisoning. Okay, third question. 62-year-old man, acutely ill, brought to the hospital. He developed nausea, diarrhea, and low-grade fever 2 days ago. Then he developed progressive, severe abdominal pain. He has a history of glaucoma and diverticulitis. He comes in very ill appearing. Blood pressure 88/62. Pulse 122. Respiratory rate 24. Temperature is elevated. Neck veins not visible. Abdomen has absent bowel sounds, generalized rebound tenderness. pH 7.12. PCO2 32. Bicarb 10. Expected PCO2 is 25. Anion gap is 20. Okay, let's go left to right. pH, patient has an acidemia. PCO2 is higher than expected. This patient is retaining carbon dioxide. He has a respiratory acidosis. He's hypoventilating. Anion gap is 20. That is 14 above normal. Bicarb is 10, which is 15 below normal. 14, 15. No other metabolic issue going on. So this patient has a hagma and a respiratory acidosis. Question 4. Severely intellectually disabled 46-year-old male is brought to the ED by neighbors after he was found down in his garage. He is obtunded. His clothing is very heavily soiled with liquid stool and urine. He's afebrile. He has orthostatic changes. Small respirations are noted. Neurologic exam is non-focal. pH 7.26. PCO2 23. Bicarb 10. Expected PCO2 25. Anion gap is 11. Going left to right, this patient has an acidemia. PCO2 is about equal to expected PCO2. There's no additional respiratory acidosis or alkalosis. Bicarb is 10, definite metabolic acidosis. Anion gap is normal. This patient has a NAGMA, a normal anion gap metabolic acidosis. Now, a couple of things here. 1, anytime you see a NAGMA, you do a urine anion gap. That's option number 2, urine anion gap, to see if it's being caused by an RTA or bicarbonate loss from the gut. And negative urine anion gap, negative urine anion gap means gut loss. A second thing about this problem is the chloride. Okay, there's kind of a rough rule of thumb that you can look at the chloride and the bicarb and kind of get a feel for what's causing the patient's metabolic acidosis, if indeed they have one. If you have a low bicarb and it's offset by a high chloride in the setting of a normal sodium, then you probably have a NAGMA. If you have a low bicarb with a normal chloride in the setting of a normal sodium, then you have a HAGMA. And you can look at this just by seeing how anion gap is calculated. Sodium minus the sum of chloride plus bicarb. This one's odd. You can see the chloride is 109. What makes this different is that the sodium is low, 130. So you can be tricked by trying to use this rule of thumb. It's always best to do the calculations. Third one about this is this patient was obtunded. You weren't sure why, and you should do an osmolar gap. Now, neither urine studies nor serum osmolar gap was measured, but you would do it. Question number 5. 28-year-old man swallows a bottle of pills in a fit of despondency. pH 7.36, PCO2 22, bicarb 12, expected PCO2 27, anion gap 19. Left to right, this patient has a normal pH. PCO2 is 22, which is less than the expected PCO2. So he's blowing off some of the CO2. He's hyperventilating. He has a respiratory alkalosis. Bicarb is low. Anion gap is high. He has a HAGMA. Do the 4B calculation. The increase, 19 is 13 more than 6, so there's a plus 13 increase in anion gap, and a bicarb of 12 is 13 less than the normal bicarb of 25. So we have 13, 13, no additional metabolic acid-base issue. This patient has a respiratory alkalosis and a HAGMA. Question number 6. We have a 45-year-old man with diabetes and hypertension. He stopped taking his medications a week ago. He presents with extensive vomiting, thirst, polyuria, and a blood glucose of 556. pH 7.39, PCO2 38, bicarb 22, expected PCO2 37. We have an anion gap of 23, so we have a high anion gap metabolic acidosis. Going left to right, okay, we have an alkalemia. PCO2 is the same as expected PCO2. No other problem there. Bicarb is 22, neutral. Okay. But anion gap is elevated. It's 17 above normal. We only have a 3 drop in bicarb. So we have a HAGMA, definitely. We have a metabolic acidosis, definitely, by definition. But the bicarb is much higher than expected. So what's going on? We're having a metabolic alkalosis in addition to the HAGMA. So this patient has a HAGMA and a metabolic alkalosis. Question number 7. We'll just get right into this calculation. pH 7.49. PCO2 20, bicarb 15. 15 plus 15 gives us an expected bicarb of 30. Anion gap is 18. We have another HAGMA here. So let's compare the increase in anion gap with the decrease in bicarb. So 18 is 12 more than the 6 of normal, so it's plus 12. Bicarb is minus 10 from normal. 15 is 10 less than 25, so they're about the same. No other metabolic thing going on there. Left to right, we have an alkalemia. This patient's PCO2 is much less than the expected PCO2. So this patient is hyperventilating, blowing off CO2, and has a respiratory alkalosis. So the patient has a HAGMA and a respiratory alkalosis with an alkalemia. This is a common presentation for aspirin overdose. Okay, number 8. Here we have a 67-year-old man with chronic severe COPD and heart failure. He's on diuretics and he's presenting with shortness of breath, fever, and cough with purulent sputum. Temperature of 102.3, blood pressure 80/50, heart rate 135, respiratory rate 24, pulse ox 82%, chest x-ray severe multilobar pneumonia. pH 7.10, PCO2 50, bicarb 15. Expected PCO2 would be 30. 15 plus 15 is 30. Anion gap is 30, which is 24 more than normal. Because we have a HAGMA, we further check to see if the increase in anion gap is about equal to the decrease in bicarb. So we have a 24 increase in anion gap above normal. 15 is 10 less than 25. So we have a 10 drop in bicarb versus a 24 rise in anion gap. So that means our bicarb isn't near as low as we expect it to be. And that can only mean we have a metabolic alkalosis on top of that. So we have a respiratory acidosis. The PCO2 is much higher than expected PCO2. And we have a HAGMA and a metabolic alkalosis with this patient. We have a respiratory acidosis, we have a HAGMA, and we have a metabolic alkalosis. Last question. We have a 64-year-old obese lady with obesity, hypoventilation syndrome, and COPD. She has pulmonary hypertension and cor pulmonale, treated with diuretics. She is having trouble breathing. pH 7.39, PCO2 60, bicarb 35, expected PCO2 50, anion gap 9. Left to right, we have an alkalemia. We have CO2 retention. The PCO2 is higher than expected. So we have a respiratory acidosis from hypoventilation. We also have a metabolic alkalosis. Just looking at the bicarb. Bicarb is high, so that means metabolic alkalosis. No anion gap increase, so this patient has a respiratory acidosis and a metabolic alkalosis. Okay, in summary, really do remember pH, PCO2, expected PCO2, bicarb, anion gap. Learn to glance at the electrolytes. ABGs may not be available very often, but glance at the electrolytes of every patient so that you can very quickly do the step 3 and 4 A and B as necessary to determine their metabolic status. Just for practice. It's great. And do the calculations. Don't use rule of thumbs. That's it. I hope you find this helpful.